Inshallah, we'll present this quiz cases as a revision before the coming examination of the module, and I will try to explain the cases in English so that it can be of benefit for those who cannot understand the Arabic words. Then we'll start by the first case, and here you can see an MRI T1 weighted image and T2 of the spine. And can you see the lesion? Anybody?
Embolic type 2.
Yes. Where?
In L5S1.
Okay. And we have at
lower end plate of the L5.
Okay. When at L5S1 disc, and you see some bone marrow changes in the lower border of L5 and the upper border of S1, and these bone marrow changes are due to edema because they appear of low signal in the T1 and high signal in the T2 weighted image. So the right answer is bone marrow edema, which is type 1 degenerative changes. As you all know that we have three types of bone marrow changes. Type 1 is bone marrow edema, type 2 is fatty infiltration, and type 3 is the bone sclerosis. Actually, the most important one is the type 1 changes, where you can see bone marrow edema of the opposing end plates, and the edema appears of low signal in the T1 and high signal in the T2 weighted image. But it's very important to know that the degenerated disc should be black in the T2 weighted image. Then if you see the disc of bright signal in the T2 weighted image, you know that is inflamed. And this is discitis, which is absolutely different from just a bone marrow edema as degenerative changes at the opposing vertebral end plates. Then anyone can ask, what about if the inflammation in the disc has healed? Then you got a black disc with residual bone marrow edema, which cannot be differentiated from type 1 bone marrow edema secondary to degeneration. And at that time, you do not need to differentiate because both conditions have no specific treatment and they do not require any further evaluation. Then what do you think about this case?
Disc herniation.
Yeah.
MRI T1 sagittal, T2 sagittal.
Yeah.
T2 axial.
T1 axial,
cuts.
T2 axial.
Yeah, T2 axial. L45 disc herniation.
Yes. To which side, left or right?
Central, right side.
It is more,
paracentral.
the main bulk of the disc is central and is relatively encroaching more on the right neural foramen, and this is the diagnosis. This is disc herniation, and you know that the disc is diagnosed as herniation even without the need for the axial images if you see that the disc is extending below the vertebral end plate or above the upper vertebral end plate. Then you consider this as disc herniation and you need the axial to know the direction of the disc. Then what do you think of this?
دكتور بعد اذنك الحاله اللي قبلها فيها هيمانجيوما.
Where?
في vertebral
This
hemangiomas.
one? Yes.
أيوه.
And
ها.
meningioma is an incidental finding, and you may mention, of course, in the exam.
Sagittal MRI, MRI of lumbosacral region.
Yeah.
This neurofibroma, I think sagittal MRI, T1 post contrast,
Yes. And this is MRI.
showing mild enhancement
Yes.
with the cystic regeneration neurofibroma.
Okay.
It is subdural lesions.
Yes. This is an intradural or subdural pathology, and then this mass.
Subdural pathology.
Yes, this mass is partly cystic and partly solid. It shows heterogeneous enhancement. And if you look carefully and you see another lesion lower down, then the diagnosis of multiple intradural lesions, one of the good possibilities is neurofibroma. Then if you see cystic changes within the lesion, then you have to select the possibility. Yes, you have to select the possibility of schwannoma because it has a good incidence of internal cystic changes. And this is the differential diagnosis, which will be repeated many times, of intradural lesions. Intradural lesions, the main lesions are the meningioma and the neurofibroma. Also, schwannoma is considered if you see cystic changes within the lesion. To differentiate between meningioma and the neurofibroma, any meningioma has a homogeneous enhancement and the dural tail. It does not extend through the foramen. But the neurofibroma can be heterogeneously enhanced and it does not have a dural tear and may extend through the foramen. Then you got other lesions that can exist inside the subdural space, including metastasis if you know that the patient had primary malignancy. And one of the well-known lesions in this area in the lumbar region is the phylum terminal ependymoma, also should be included in the differential diagnosis. Then it is written in the literature that in order to diagnose meningioma, one of the helpful signs is this appearance, which is known as ginkgo leaf. I don't know if I pronounce this right or not. And this is the correlated image. This may be seen in some cases and help you to spot the diagnosis of meningioma. Then there are some lesions occurring intradural, but they are not neoplastic, like lipoma, for example. And the three important lesions occur anywhere in the body together, meaning that if this place can can be the seat of arachnoid cyst, it can be also the seat for epidermoid and the dermoid cyst. Then this intradural space can be the seat of dermoid, then it can be the seat of epidermoid, and it can be the seat of arachnoid cyst. Then if you have a cystic lesion inside the dura, this includes one of three possibilities. Number one, arachnoid cyst. Number two, epidermoid cyst. Number three, cystic schwannoma. Then how can you discriminate the three? By diffusion. If you perform diffusion weighted images, only the epidermoid cyst will show diffusion restriction, while arachnoid cyst and cystic schwannoma will not show diffusion restriction. And sometimes, as I have mentioned in the literature, in the lectures, that the disc may herniate and extend inside the dural space. And at that time, you know that this is disc because it is exactly at the level of the disc. Then what do you think about this?
Ependymoma
No, caudal regression syndrome.
Yes.
Caudal regression
caudal
syndrome.
regression syndrome, cephal cord.
Yes, okay. this is the caudal regression syndrome with the characteristic appearance of the terminal part of the cord and may be associated with anomalous vertebra, including agenesis of the sacrum either totally or partly. And this agenesis of the sacrum may be also associated with some agenesis of the lumbar vertebrae as well. Then agenesis of the vertebrae can extend at the level to the level of D10, and above this level is incompatible with life. But you can see in this picture that there is an adult human being with no lower half of the body, and this human being uh, is alive, as you can see here, and this is not incompatible with life unless the agenesis extends to the dorsal number 10 vertebra. Then if you look carefully in the plain film and you see that there is no sacrum and the iliac bones are very close to each other, and this is sometimes known as kissing of the iliac bones, for example, and you do not see the sacrum. Also, if you look in the MRI, you can see only one or two sacral segments, or even no sacral segments at all. In the MRI, and you see the typical blunted appearance of the conus. And this is the normal appearance of the conus, and this is the blunted appearance of the conus in caudal regression syndrome with absence of the remaining segments of the sacrum, and you see only two segments here. And this is caudal regression with total fusion of the iliac bones, and almost all the lumbar vertebrae are not present. And this is also another example. You see the approximation of the iliac bones, and here you see fusion of the iliac bones, and only L1 vertebra is present. And what do you think of this case?
Spondylodiscitis?
At what level?
Metastasis, I think. Metastasis. Metastasis.
With bone involvement.
Okay, then you got multiple lesions, and this lesion at L3, and there is another lesion at D12, is associated with epidural
Soft tissue.
Then multiplicity of the lesions are in the differential diagnosis of three: metastasis, lymphoma, and myeloma. Then if you see the lesions that are of variable size, meaning that one small lesion and one big lesion involving the whole vertebrae, you put more better the possibility of metastatic development. Then in the previous days before CT and MRI, we used to diagnose metastasis by this sign, which is known as the pedicle sign. And you see the pedicle of the vertebra and the opposite pedicle. But here you see the right pedicle, but you don't see the left pedicle. And this was one of the signs of metastasis by plain X-ray. And here is known also as the winking owl sign, where you can see the pedicle on the right, but you cannot see the pedicle on the left. And here you can also see the two opposite pedicles in a normal vertebra. And metastasis can be osteolytic and it can be osteosclerotic, as you know. And the metastasis can be associated with extraosseous soft tissue component. And here you classically see the absent pedicle compared to the left side. Then variable sizes of the lesions will support the diagnosis of metastasis. And you remember that you do not need to inject contrast material for the diagnosis of metastasis, because metastatic deposits are of low signal in the T1, they are better appreciated. If you go to the T2, you may miss a lot of metastatic lesions because of the increased signal of the deposit and the decreased signal of the bone marrow. If you inject contrast material, metastasis will enhance and the background of bone marrow fat is bright, then you will lose most of the metastatic lesions. Then you do not need to inject contrast material and to add more cost for the patient, especially in cases of metastatic lesions. Then what do you think of this?
This is
intramedullary lesion.
intramural.
Intramedullary.
Intramedullary or intradural?
Subdural.
Subdural. Yes. If you look
Subdural.
carefully, as I mentioned in the lectures, if you look to
It's
the
widening for CSF.
yes, very good. There is widening of the CSF space while approaching the lesion. This means that it is a subdural pathology. And
Subdural.
the subdural pathology is of low signal in the T1 and the T2, and it shows homogeneous post-contrast enhancement.
Meningioma.
Meningioma.
Meningioma. Meningioma.
Meningioma. And you know from the brain pictures that meningioma has its new name, which is the
Solitary fibrous tumor.
fibrous tumor. Then it is not strange to see this name in the spine as well. If you are confronted by a lesion like this, and you can say this is a meningioma, or you can say that this is a solitary fibrous tumor. Then what do you think of this?
Sir, there is
Sorry?
Intramedullary lesion.
Intramedullary lesions.
Yes?
Yes, intramedullary lesion.
What do you think?
Ependymoma.
It's an
No, it's long segment.
extensive lesion for
Extensive long segment.
Astrocytoma.
Astrocytoma.
But for astrocytoma, you should have a solid component and a cystic component. But here you see only a cystic component, which indicates that this is a syrinx, dilatation of the
Yes.
central spinal canal. Then you may ask, what about the abnormal signal within the syrinx? And this is due to turbulence.
Neurofibroma.
No. This is due
Hemorrhage.
to
Hemorrhage.
no. This is due to turbulence of flow inside the syrinx because it is very big. Then if it is a narrow syrinx, the jet of flow will show normal signal. But if the syrinx is big, then you suspect that there is some flow artifact. Then if you look carefully at the foramen magnum, and you see that the tonsil of the cerebellum is going down below the level of the foramen magnum. Actually, this issue
Malformation.
yes,
Chiari
this is
malformation.
Chiari type of malformation, which will be discussed in details in the pediatric module. But we may have some informations about this Chiari, which represents about 40% of the causes of hydrocephalus in children and is associated always in 100% of the cases by a meningocoel. Then one of the important issues whenever you are confronted by a case of supratentorial hydrocephalus is to ask the parents of the patient if he or she has a meningocoel. This will support diagnosis of care. Then if you look here and you see that part of the cerebellum okay, part of the cerebellum is herniating into the upper part of the cervical spinal canal. And this will result in stretching and almost obliteration of the fourth ventricle. This is the normal appearance of the fourth ventricle, and this is a stretched, almost obliterated fourth ventricle, which will result in supratentorial hydrocephalic changes. Then the changes at the posterior fossa, you got a small posterior fossa because of the herniation of some of its contents and widening of the foramen magnum and the convexity of the clivus to let the way for the descending parts of the cerebellum. And this is one of the signs, as mentioned by the literature, known as the worthy Valentine gift, where you see that the brainstem looks like heart shape. And this is because of the downward traction on the tectum of the brain due to herniation of the fourth ventricle. Okay, what do you think of this case?
Epidural hematoma. Epidural hematoma.
Okay, both possibilities are good, and there is a bright lesion in the T1 in the subdural space, and is also bright in the T2 weighted image. Then both hematoma and the lipoma can appear like this. And in order to differentiate, and you should have the fat suppression to differentiate between hematoma and the lipoma, and this was the case of lipoma. Okay, what do you think of this?
Lipomyelomyelocele.
Lipomyelocele. Then sometimes I mentioned in the of relatively old lectures that this is the lipomeningeomyelocele, but actually you do not have a meningeocele here, and you have a big lipoma or a big fatty mass that is continuous both inside the spinal canal and outside the spinal canal. This fatty mass is bright in the T1, in the T2, and dark in the fat suppressed images. And if you see a mass like this, which has an intraspinal component and extraspinal component, this is known as lipomyelocele. It is usually associated with the spina bifida and also with low termination of the spinal cord, what is known as tethered cord. Yes, and this is another example. You see a big fatty mass in the back of the child, which is continuous with another fatty mass inside the spinal canal through a spina bifida associated with low termination of the spinal cord. And this is another example of lipomyelocele with a fatty mass. In the sagittal images, you may fail to see the continuation between both, but in the axial images, you can easily appreciate the site of communication. And this is another example with suppression of the fat in the STER images. Then what do you think of this?
Subdural lesion.
Yes, subdural lesion.
Subdural lesions.
Yeah, what do you think?
Do signal in T1, ISO intense, in T1 and T2 weighted image.
No, this is T2 is ISO intense and enhanced in the
meningioma.
Yes, this is a meningioma. This is a subdural lesion because widening of the epidural space, and you see a broad base with the dura. This is one of the possibilities. You remember intradural lesions include mainly meningioma, neurofibroma, and schwannoma. If the patient is known to have a primary malignancy, consider metastasis, then the non-neoplastic lesions will include arachnoid, epidermoid, and the dermoid cysts. Then this is a
Lipoma.
this is a
No, it is meningocele. Meningocele.
This is the post-operative spine.
Pseudomeningocele. Is post-operative, so it is pseudomeningocele.
Yes, and this is a known complication after surgery that if the dura is injured, you got leak of the CSF at the site of laminectomy, and this CSF will collect to form a cystic lesion that because of CSF signal in the T1 and T2, it is known as pseudomeningocele. And what do you think of this?
Arachnoid arachnoiditis.
Yes, very good.
Empty cecal sac.
empty
Empty cecal
cecal
sac.
In this
sign.
area, you got empty cecal sac, and then this you got clump of the or adherence of the nerve roots together with each other, and this is arachnoiditis. And you know that arachnoiditis is due to inflammation of the arachnoid membrane, resulting in adherence of the nerve roots together, and this may result in empty cecal sac sign or may result in the pseudocord sign, and this is the normal appearance of the nerve roots. Then what do you think of this?
Metastasis.
Okay, and these are metastatic deposits.
Metastasis.
As we have mentioned before, you got a lesion here, another
Multiple.
lesion here, another
Multiplicity.
in, and this is the T2, and this is post contrast. Then you consider the possibility of metastasis. What do you think of this?
Low cord due to phylum
Treated cord.
fatty phylum terminal.
Cord.
No, this is the cord which is normally terminating here.
Lipoma of the phylum terminal. What?
Lipoma of the phylum will appear as a line of increased signal in the T1 along the phylum. This is lipoma, but not of the phylum, and it is located
The spinal lipoma.
in the
Dorsal.
yes, it is known as this is a lipoma which is present in the epidural space compressing the cecal sac, is known as epidural lipomatosis. And this lipomatosis have a characteristic MRI appearance which looks like the Y letter. And this is because of the compression of the cecal sac from both sides, resulting in this appearance. Epidural lipomatosis is a disease where there is excessive accumulation of fat in the epidural space. The causes are usually due to obesity and maybe idiopathic and maybe due to Cushing syndrome or long-term steroid administration, Sherman disease, spinal surgery, and epidural lipomatosis usually occur in the lower lumbar region. And if you see this Y configuration, you can easily diagnose the lesion. Then what do you think of this?
Can I ask you, Dr. Mamdouh, for a short break?
Yeah.
For who want to pray Maghrib?
Yes, we in 2 minutes we'll stop and
5 minutes, okay.
allow for 10 minutes for break, then we go back, okay?
Okay, thank you.
Let us stop here, okay? We'll stop here and we'll continue after 2 minutes, okay, Dr. Sharif?
Okay, let it 5 minutes, okay?
No, the remaining time is 4. Then
okay.
You want to have a break for 5 minutes? Okay.
Yes, a break for 5 minutes. Thank you.
All right, go ahead.